Okay, good evening, everybody. Thank you very much for coming along to this evening's inaugural lecture by Professor Alex Trompeter. It's lovely to see people here in person, and also I know we have people watching online either in real time or who are going to be watching on catch up later. So for those who don't know me, my name's Professor Natalie Armstrong. I'm the incoming Executive Dean for the Integrated School of Health and Medical Sciences across City St George's, and it's a real pleasure to be here introducing the inaugural lecture this evening. So inaugural lectures, as anybody in my position will tell you, are a lovely event to have in the academic calendar. They are an opportunity for newly arrived or promoted professors to really mark this significant milestone in their academic achievement and in their academic career. They're a wonderful opportunity for the speaker to introduce themselves on perhaps a slightly more personal level than they would for other academic talks, to update colleagues on their achievements to date and their future plans, and to share their research perhaps with a slightly different audience than usual. It's also a chance to really acknowledge the support they've had from friends and family along the way, and from colleagues, mentors and collaborators, both past and present. It's lovely to see so many of Alex's colleagues here in the room, and I know there are family and friends who are watching online who couldn't be here this evening. So before I introduce Alex, I will just say a little bit about him. It's very clear to me immediately that he is a man of significant achievement, and someone is very desperate to come in and hear him speak. Come on here. A man of significant achievement, and I'm sure that we will hear some more about at least some of these activities and achievements throughout the course of the lecture. So Professor Alex Trompeter works at St George's University Hospital and holds the position of Professor of Practice in orthopaedic trauma surgery at the university. His specific clinical interests are the management of complex fractures, bone infection, non-union, deformity correction and limb lengthening. He has a regular orthoplastic microbiology MDT clinic, as well as delivering the region's amputation service. Alex graduated from Guy's and St Thomas's Medical School in 2003, completing his specialist training in trauma and orthopaedics in the South West Thames rotation in 2012, and won the Sir Walter Mercer Gold Medal for the FRCS examinations in 2011. He undertook specialist fellowship training in trauma and limb reconstruction, both in the UK and overseas. He was awarded the Braun Travelling Fellowship to Massachusetts General Hospital in the USA by the British Orthopaedic Association, and a Travelling Fellowship to the Oxford Bone Infection Unit by the British Limb Reconstruction Society. He's actively involved in research and education locally, nationally and internationally. He regularly teaches and lectures in his specialist areas. He's previously been Training Programme Director for the South West London Orthopaedic Rotation, chairs the British Limb Reconstruction Society Research Committee, and is Trauma Lead on the British Orthopaedic Association Clinical Standards Committee. Alongside all of this, he's widely published in his field and has successfully defended his PhD thesis on tibial trauma. He holds numerous external academic, education and research and design roles, including working with industry partners in many instances. So I'm delighted to be introducing Professor Alex Trompeter to give an inaugural lecture this evening, reflecting on his clinical, academic, educational and leadership journey throughout his work in orthopaedic trauma. So please join me in welcoming Alex to deliver his inaugural lecture, Challenging Yourself, Challenging Dogma and Managing the Unexpected.
Thank you. Thank you very much. It's an absolute honour and privilege to be here this evening. I'm going to deliver my talk in three parts. The first, I'll cover a little bit about my career to date, the challenges I've faced. The middle section will be looking at the challenging of dogma, something I feel very passionate about. And the third section will be dealing with maybe the unexpected challenges that come your way. I thought, oh, you know, could gaze into the ceiling, looking longingly as to what my future might hold, but I won't bore you with my childhood. because it was actually fairly ordinary. So I'm actually going to start at the point of my first day as a consultant there on the left, up to where we are now. And I'm going to talk to you a little bit about my clinical work, my educational work, my work in research, my work around policy, and some personal goals and challenges that I've met along the way. I've used the term challenge in the title because I think it's quite pertinent to me and what I do. I think my work, my clinical work, could be considered quite challenging. I think we all work in very challenging areas, but within orthopedics, there is a degree of knowledge that some of what we do in limb reconstruction is particularly challenging. I think it certainly stretches my determination and tests my determination. But I think challenging is also important in terms of pushing people when you've got questions to ask. Anyone who knows me knows I have fingers in quite a few pies. So I thought I'd look at some of those pies and try and understand what on earth I was doing putting my fingers in them to start with. So I'm going to look at the clinical first, and this is the area where I've spent obviously my career to date. I am a surgeon, and you'll know that from the introduction. I'm an orthopedic surgeon. But just to fill you in a little bit more about what I do, I'm a trauma and limb reconstruction surgeon, and that means that I look after people with fractures, usually pretty nasty fractures, typically fractures that involve joints or very challenging fractures to fix. I look after people who are missing bits of their skeleton, usually through trauma or infection, maybe bones that haven't healed, what we call non-union. Infected fractures or fractures that have fallen apart, and sometimes I see patients at the sort of point of their 7th, 8th, 9th operation by the time they get to me. We do limb lengthening, so this is a picture of a motorized lengthening nail, some of the new technology we're using. Deformity correction, how we straighten bent bones, and amputation surgery. And I went to a conference once in America, and a limb reconstruction surgeon got up and he said, I do all of this work and it's a bit like I'm a bottom feeder. I'm taking all the stuff that no one else wants in orthopedics that's filtering to the bottom. You'll notice there's no joint replacement surgery there. There's no ACL surgery or carpal tunnels or any of the good stuff that, you know, could be considered sort of nice and predictable and relaxed. And it's all the stuff that nobody else wants. And I like this slide because I don't think I'm a bottom feeder. I think it's a fantastic area of orthopedics where there's an awful lot of unknowns and there's an awful lot of research gaps, and to me that means there's immense opportunity to explore it for the future. One of the things that's really apparent, and this is a slide from a photograph of a flip chart from when I was teaching on a course recently where we had a brainstorming session about all of the people that you might have involved in managing a patient on a limb reconstruction journey. And it's an immense amount of people involved for many of these patients. And that really reflects the joy that I have in my daily clinical practice, because I get to interact with so many incredible people. There are surgeons up there, and the first thing that one of the people said was they mustn't be horrible. You'll notice up there are the theatre team, there are the rehab teams. There's Becky just sat there in the audience, our specialist nurse, pain team, psychiatrist, allied surgical specialties like plastics, microbiology, the immense number of people we come across. And it's really important because the journey for these patients can be huge. Some of these patients, we're talking 2-3 years of repeat surgeries and the journey through clinic. These are not quick fixes. And it's been an immense journey for me in building this service. When I started at St George's, there was no real formalised limb reconstruction or complex trauma service. Some of my colleagues did some work in it, but no one had kind of put their hand up and said, this is my specialist niche practice, I want to do this. It requires a lot of energy. The patients often can have a lot of energy partaken into them in the nature of the injuries they've sustained, but it takes a lot of energy and effort to keep going for the patient on the journey, and for you as the individual and the surgeon as maybe the person steering the team with you to keep going with that energy and enthusiasm in managing these patients. Infection rears its head continually. I probably have a higher infection rate than virtually any of my colleagues because there is a natural infection rate that occurs with this work, and many of my patients are infected before I even get there. And sometimes you feel a bit like a punching bag. You know, the patients get frustrated. Becky has become my sort of punching bag for me. She get not because I'm punching her, but because she takes the blows from some of the patients. But you really do need a thick skin for this work, both through the complications that you may face and the frustrations that the patients may vent upon you. But the teamwork has been amazing, and the rewards at the end of it, when the patients engage in their journey, are quite remarkable. These are the circular cages that I use, and on the left there, someone's jazzed their one up for Halloween. This guy showed me how determined he was with his rehab, that he's on his turbo trainer at home with his frame on his leg. And this lady turned her frame into some sort of jewellery at the end of it. And occasionally you get the most fantastic gifts from your patients. I have no idea to this day what my patient gave me. I think it might have been some homemade hooch. It looks like something that the lab should be analysing. But anyhow, that's still to the day one of the most memorable gifts I've ever had from a patient. We also get to explore and push boundaries with some of the new technology that we've been using. This is not by any means me pushing it as an individual. There's a group of us surgeons in the UK and globally that have been using 3D bespoke printed implants for replacing missing pieces of bone. This is this cage that you can see down here, which is a really exciting and novel bit of tech, but it's unknown. And then through our amputation service here at St George's, we're the only unit in the country to have offered anything to do with osseointegration, which is where an amputee who would typically use the normal sleeve that goes on the leg has an implant fixed directly into their skeleton where the prosthetic limb then attaches to it. And it's a very niche, very limited service, but it was a real pleasure and honour and privilege to be involved, even if those patients are perhaps some of the hardest work of all. The patients that I look after, it's been really exciting. We also have pretty tough days at work. They can be challenging, and there are some colleagues here who have worked with me on these days, and I remember both of these events pretty well, and I'm sure anyone else that was on duty on those days will. These test your mettle. These test your resilience in your clinical judgment making, your emotional resilience, and whether you really are in the right place and doing the right job. And I have to say, as tough as these days were, they were probably some of the best days in terms of how I felt I performed at work. I think they bring out the best in us sometimes, and it's a shame that you have to get through those events to see that, but those that were on know what I mean, and you leave with a sense of pride as well as rolling things through your head that perhaps you should never have seen or been involved in. A very emotional part of our work, but something incredibly rewarding and privileged to be involved in. And as I say, occasionally things don't go to plan. And I think the challenges that I've learned through my clinical practice when things haven't gone to plan is normally there's actually a reason and something you can find along the way that led to that. And maybe one thing, maybe a few things, but reflecting when things haven't gone well on what could have gone differently is important, but dwelling when things haven't gone well and letting it get to you is something that you need to try and push back against. And I think resilience as a surgeon is something we have to learn because there are very tangible events, very tangible episodes that we're involved in patient care where there may be something has happened that hasn't come to the result we'd have hoped for. And how you deal with that is something that you really need to learn over a period of time. And I think I'm very different now in managing complications to when I started. What about education? What have I challenged myself in the educational world? Well, I've done a lot of teaching and training at St George's. I've gone through the challenges of learning new roles. I've taken on the role of SSC lead, SSC1 lead in the university. That's the coursework modules. I'm learning a new language. I'm learning new things that I never really thought I would be involved in. And it's fantastic to work with a new bunch of people and learn about things like standard setting in marking of exams and so forth. Absolutely love it. I've spent my time teaching trainees in surgical training and then teaching nationally and internationally through courses and industry. And it's been an absolute privilege. The thing I've learned above all else when I teach has been for me, I think teaching philosophy, teaching concept, teaching logic is so important. And if I take someone on that journey with me, I can see that they're learning as we go, rather than just trying to teach fact. So I always make it my my mantra when I'm teaching, that I'm teaching it in a way that I know they're going to understand. They're going to take home that journey, that message with them. And then they can go away, people can go away and look up the facts and the figures. I very rarely try and teach facts or figures. I think if you understand concept, that's half the battle done. And that's really where I sit. So the philosophy behind what I do is how I teach it. A lot of drawing. My fellows in here with me, he'll know I spend my whole life in theatre drawing pictures, explaining what we're going to do and why. And if it doesn't have a logical foundation, then you're probably not explaining it properly. If you can understand the logic, you'll get it. My time as training program director was some of the most rewarding. It has been an absolute privilege. I think I counted probably somewhere in the region of 80 or 90 trainees in my 6 years through the system, and absolutely brilliant to see some of them as colleagues now, some of them as colleagues in other hospitals. Others have left and gone on to do other things, and I'm still in touch with them, and I'm seeing them forge the most incredible careers and lives. And to have been part of that has been absolutely wonderful. They threw me the most incredible party when I stepped down as TPD. They didn't need to do this, but it told me I must have done something right along the way, and it was an absolute joy. They also made me the most phenomenal theatre hat that I wear with great pride when I'm with them. I've also had a series of fellows. Fellows are the kind of highest level of training before you become consultant. And our fellowship program here in trauma and limb reconstruction started as really a small fellowship, not really anything structured per se. And I'm very proud and very privileged to now have built it into an internationally recognized fellowship. These are the nations where some of, I think, 9 of the last 11 of my fellows have come from. And so it's absolutely mind-blowing to feel that you're training people who are now taking what you've taught them and going back to their units around the world and sharing the knowledge you've shared with them to their trainees. So it's one of the biggest pleasures I have in my life, of seeing someone start their fellowship with me and then finish and going off into their independent practice. What about research? This was my first paper, 2008. I absolutely hated writing it. I resented it. It was like a millstone around my neck. It took weeks and weeks and weeks to get there. It got rejected about 750 times. Finally, I got it over the line. And it's a groundbreaking paper, that one. But some 50, what was it, 17 years later or something, you know, not doing too badly on the research front, about 170 odd publications. And it's really, what I've learned is that this is where a lot of difference can be made. And I think for me, increasingly, the academic world has opened my eyes into where you can instigate change, because data and evidence is what allows people to be persuaded when you're having an argument. Passion will do so much, but if you don't have the evidence to back it up, it's very hard to convince people. I will say that writing textbooks is the opposite. That has been an exercise and a headache for me. And it was his great pride every year that I put my £18 of royalties on my tax return. But I would say that textbooks are a challenge and a half. By the time you've finished writing it and gone through 15 computer crashes, losing everything, the data in it and the evidence in it is usually out of date. These guys asked me if I wanted to write a second edition. I haven't actually yet replied to the email. But I will say that one of the things I've learned the most from a research point of view is getting involved in reviewing for journals and then moving my way up onto the editorial board for these 2 journals. It's a phenomenal experience. The learning that I've exposed myself to, the challenges that I've taken on in trying to understand how a journal works, how to review, what I've learned has made me better at my research by some distance. And it's an honour and a privilege, especially the Bone and Joint Journal, which is our flagship journal in orthopaedics in the UK. To be on the editorial board of that is absolutely brilliant. From a personal perspective, I've reflected on research, and I've looked at, you know, what a lot of research is, and there's this massive gulf between the case report, case series end of the spectrum and the big grant funded studies end of the spectrum. And I've always wondered, how do you navigate the journey in between? Because there's a massive jump. You know, anyone who's done any grant applications or tried to do any grant funded work will know it's enormously challenging. And I think there is a gap, and it's in the big data studies. And I'm very fortunate. I have a great colleague up in Middlesbrough, Will Eardley, who I work incredibly closely with in various roles, teaching and in our policy stuff. But we both have a similar vision about data. And we looked at this and have collated quite a few papers now where we've collaborated nationally with fairly rapid projects to look at the real world picture of what's been happening in orthopedic trauma across the country. And this is informing the next layers of research that we have. And this is so much more impactful than single center stuff. Takes a lot more effort and energy, but doesn't require the enormous grant funding that sometimes is seen as a barrier to research for some people. So I think there is an absolute home for this style of research going forward, and it's been a really exciting thing to work in, and brought with it its own challenges of how you collaborate, how you collect data, what data sets do you need to get people to engage without getting it so small that it's not meaningful versus so big, for example, that they turn themselves off from wanting to be in part of it. And that all culminated in a bizarre, slightly challenging exercise of writing my own PhD thesis a couple of years ago now on this. And I'm reflecting on what I'd been doing up till now. Actually, it was an incredibly cathartic process and allowed me to really distill my thoughts around my own research and gave me some great ideas about where I'm going to go next in my research and academic work. It was definitely hard work, but nonetheless, I think for me, it really gave me reassurance that actually I'd been doing something, because it's very rare that you go back and reflect on the papers you've written. You know, you write it, you park it, it's done, and you go on to the next one. And so this actually made me pull out the theme of papers. There's about 70 papers I included in my thesis, all themed around tibial trauma, and made me realize that there was quite a body of work there, that I had thought about certain things. There were themes, and it allowed me to reflect on those. So I feel very proud to have achieved that. Briefly about the policy stuff. So the British Orthopaedic Association is our specialist organisation of the Royal College of Surgeons. Orthopaedics is quite a big specialty. There are several thousand orthopaedic surgeons in the country. So this organisation carries with it quite a bit of weight. And I'm not a political mover. I'm not someone that's sort of ever really been into the politics side, but I got involved in the trauma committee, who are responsible for helping navigate the sort of current climate in delivering trauma care in the UK, and then specifically in the writing of our national guidelines. For anyone in the room who's orthopedic, this will be very familiar, the BOA standards, or BOASTs as they're known. These are hugely successful. They're not my original concept. This is the concept of a generation before me, but these are so well known that they are internationally citable and adopted by many other organizations around the world, not just orthopedic. But for the last few years, I have headed up the committee that writes these. And writing guidelines has been an immense challenge, learning essentially the nuances of language, learning how to balance two very different people's views on what they do and don't want to include in guidelines, and ultimately picking out topics that can be seen as aspirational and help drive change, because that's what they're there for. And I've learned an immense amount. It's some of my most rewarding work, and it's the bit that's probably made the biggest changes to clinical practice for us as orthopedic surgeons as a community. And to be part of that for me has been incredible. I also have a medical legal practice. This has been like learning Greek. It's a totally different world. It's totally alien when I've been working through it. But again, what it's done is make me reflect on my own practice as a surgeon, how I consent patients, how I talk to patients, how I record things in the notes, and kept me appraised of the literature in my specialist field. And actually, I find it an incredibly complementary piece of work to my main clinical job. So those have been my sort of challenges along the way in my career today. Not all of them, but the things that I've been busy doing. I've been busy at home as well. I really like pigs. I really do, and especially when they come like that, because what I do is I spend some time at home. I spend a day and I break it down into its different components, and then I turn it into salamis and charcuterie, and I spend a good day making all of that. And then you have to spend and hold your nerve. You have to hold your nerve for 6 weeks. You have to build a little drying cabinet. You have to see the mold growing on it and trust yourself that it might be good mold, not bad mold. You can usually tell by the colour. White mould good, black dripping sausages, don't eat them. And if you're really lucky, you end up with platefuls of homemade charcuterie that are really quite wonderful. And it's a really lovely thing because you spend a day investing time and energy and effort, and it's very scientific. And then you've got to wait. It's not like baking a cake where in an hour it comes out the oven and you know if you've made a good one or not. You've got to wait 6, 8, 10 weeks sometimes to see if this is rewarding or not. And I think that really tests your nerve. And my wife will chuckle because she knows I come home after work some days, and before I've even said hello to the kids, I'll go and check on my salamis, make sure they're okay. So, you know, it's a thing that reflects me about liking a challenge, liking to take on something that's not necessarily easy, but if you get it right, the rewards are fantastic. I also challenge myself running. I've never been a runner. I was a terrible runner at school. Those that know me know I dodged cross country at school like you wouldn't believe. But I've taken to running cross sort of country trail running because I find it incredibly mindful, cathartic. It's where a lot of my thoughts and processes get percolated and my ideas come to fruition. And this is the sort of stuff I like running on. I don't enjoy road running. Occasionally, though, I run a really long way. This is the Jurassic Coast 100. So this is a 100k run that I did a couple of years ago. I do an ultra about once a year. I've got 2 this year lined up. And this really tests your mental fortitude. You can train as much as you like running. You can be as fit as you like. But when you get to about 60 or 70k and you see a hill like these along Durdle Door, it's hard work. And, you know, there are moments in this where you go to some pretty dark places. And I think for me, it was the mental challenge much more than the physical challenge that I actually enjoyed the most. The physical was incredible. The scenery was incredible. The camaraderie you meet along the way. But pushing yourself in a physical way was something I found incredibly rewarding and something I continue to do these days. People often ask me, though, with all of that, how do I balance it? How do I manage those different spinning plates? How do I decide, you know, what do I give my time to and when? So there are 3 little rules that I try and play by in my life that help me. The first is this concept some of you may be familiar with. It's the Japanese concept of tree bathing. I don't necessarily lie there under trees, but getting outside and getting outside once or twice a week, these are all within about 2 miles of my house. This is where I live, is phenomenal. It's phenomenal for the mental well-being. I find it's where I do some of my best thinking. I wrote this talk over the last 3 months, walking the dog, running around Frensham Ponds, if those that you don't know it, and Alice Holt Forest, right by my house. And it's the scenery changes every time I have a walk. The moments of reflection, the moments of wandering, and I take my little buddy with me. He comes running with me or walking with me a couple of times a week, and I find it unbelievably important for my mindfulness and well-being. So that's the first thing I do. The second thing, I'm a bit of a consummate planner, and you'll notice this is my operating plans. These are computer-aided plans that we use for calculating the angles in a bent bone and working out if we crack it here, will it become straight or will it become more bent? Yes, you can make them worse, even though it seems impossible. And this is a folder up in theatre of about the last 10 years of my surgical plans. And again, my colleagues will know, I sit there with my coloured pens at 7 in the morning, drawing out the plan for the day, writing the script of the operation. And I think it's really important when you're doing challenging things to have a degree of planning that's gone ahead. It also means that if you're not going to plan, you can revert to the plan and ask, where did it deviate? And I think that's, again, really important. You know, when you make Lego and occasionally it's wrong, you can usually go back in the pictures to the point where you went wrong. And I find that is not dissimilar in surgical planning. But I can also take it to planning at home. This is a sketch of, my outdoor kitchen that I built myself. And I spent all my time planning that, measuring it. And it was very much case of measure 2 or 3 times and cut once. And I'm pleased to say that I used exactly the amount of timber that I bought. So I was very chuffed with that. But it all came down to planning. And I think for me, then, that's the second key thing in my rule book, if you like, of what keeps me going. The third is this. This is goes hand in hand with my wife, Kirsty. not because she's attached to the kitchen, but because she is the arbitrator of my sieve, the filter that allows me to decide what I should or shouldn't continue doing and investing my time in. And what do I mean by that? Well, you get a huge amount of stuff on your to-do list, and it grows and grows and grows. And I think when you start your consultant career especially, it's really easy to end up taking on lots and lots and lots of stuff without an understanding of what the impact is on your well-being or your ability to do and deliver. And so with Kirsty as well, about once every 6 months, but I'm getting better at it, at going sort of real time, if you like, I ask myself 3 questions. Number 1, is this thing that I've been asked to do or I'm going to take on interesting? If it isn't, got to be a real good reason to want to carry on doing it. Does it stimulate me? That's also really important. And is it of value to what I do? Does it add to my recipe around my clinical practice or my life? And if it doesn't satisfy those criteria, I ask myself really seriously whether or not I should continue taking on that task, because I found that incredibly useful. And I'm at a point now where most of the things on my to-do list all satisfy these criteria. It's quite hard to say no to stuff when you feel honoured to be asked, or it's a privilege, or someone's come to you. But if it's not going to tick your boxes like this, then there's a real question as to why you should be taking it on in the first place. And that means I'm left with this Venn diagram then of things that I'm involved in, but they're all complementary. So my clinical work, my academic work, my educational work, my policy work, my medical legal, they all complement each other. They all have a core at the same, whereby they're involved around the management of complex trauma or limb reconstruction to one degree or another. And I think that's become really increasingly important to me. And if they complement each other, that means my energy for them then is even greater. So there you go, my 3 little keys to keeping me sane. Get outside, plan it a little bit, and find yourself a good sieve. So this next few minutes, I'm going to talk a little bit more sciencey on one of the areas that I've been spending the last few years dealing with from an academic perspective. Challenging dogma. This is something really important. And as surgeons especially, I think there is an absolute acknowledgement among surgeons and probably amongst physicians that there's an awful lot of what we do in healthcare that is done because that's the way it's always been done. That's how it's been done. That's what our forefathers said. People said that. It was taught to us. This is how we do it. And, you know, in the words of Run DMC, it's like that, and that's the way it is. And people are really resistant to changing that. But I've sort of taken it upon myself to ask questions wherever I've gone around what we do on a daily basis, and ask ourselves, where is the evidence for that? Where is the evidence that, is it getting dark? It is getting very dark. Where is the evidence that, you know, in open fractures, for example, there was a classification that's based around one historic paper from one unit where one guy looked at some of his own open fractures, found an infection rate, and therefore decided that all open fractures from then on are classified in a certain way with no reflection on modern healthcare outcomes or anything. So we've challenged that. We've published a new classification system. Non-union, where a bone has failed to heal, people historically have always put bone graft in with no evidence that the bone graft makes any difference. And there are actually huge amounts of swathes of basic science, and now hopefully in my next few years clinical evidence to say that bone grafting isn't necessarily needed in many non-unions. Tourniquets is something orthopedic surgeons have used forever with no evidence that they improve anything in terms of surgical outcome. The only subjective reason to use a tourniquet is because surgeons think that the patient's bleed loss and surgery is quicker, but actually the literature doesn't even support that. So it's really interesting area. So for me, one area that I've looked at, and this actually transcends all of medicine, not just orthopedics, is what you do when you see a patient like this in your ward round in bed. And I've talked about this in this editorial, and this has been my research theme for the last few years, is around weight bearing after orthopedic injury, but it's actually about weight bearing as a whole, as a patient. We know that this lady who's lying in bed doing nothing is exposed to pretty much identical conditions that this chap experiences when he spends 6 months on the International Space Station. You know that the literature will tell us, the evidence will tell us, that if you go into space in a zero gravity environment, after 3 to 6 months, you will come back missing a third of your bone mass and a third of your muscle mass. You will have osteoporosis and sarcopenia. We also know that if you lie down and do nothing, this is an amazing study. If you were ever a medical student and paid to be a patient in a study, this is the one you wanted to do. Lie down for 10 days, don't get out of bed. That was it. And then they measured a variety of physiological parameters. And if you lie down and do nothing, funnily enough, your body turns off broadly. You lose muscle strength, you lose cardiac capacity, you lose stair climbing power. Unbelievable amount of physiological insult occurs through inactivity. Further studies have shown this in the basic science about muscle loss and the rate at which you lose bone mineral density and muscle mass is far faster than the rate at which you can recover it. So you have to remember that these frail old people with perhaps very little reserve will lose their muscle mass but may never recover it. And then the other issues come with prolonged immobility, all the things that we're used to knowing about on our wardrobes. So overall, if you're non-weight bearing, which is the norm, remember dogma in orthopedics, who has ever had a fracture in the room and who was told to non-weight bear or knows someone that was put in a cast and told to non-weight bear for 6 weeks, 8 weeks, 12 weeks, okay? But all of that does, as we know from the literature, cause this list of negative effects. And there may well be then healthcare associated costs with this, etc. But the concept of early mobilization after fracture surgery isn't new. This guy, Robert Dennis, is one of the fathers of fracture fixation, said in sort of about 1940, early active mobilization should be one of the pillars of what we do in fracture reconstruction. And he also noticed that if you stuck people in a cast after surgery, the benefit of surgery was lost. And there may even be the permanent stigmata of disease. Again, I take you back to anyone who's had a family member or a child in a cast. When you take that cast off, the skin's flaky, the arm or the leg's a bit withered, it's hairy, it's lost a load of muscle, and it takes weeks and weeks and weeks to come back from that. Yet, as an orthopedic community, we still tell people to not walk on their limbs after fractures. Why do we bear weight then? What's the opposite to that? This guy is a guy called Julius Wolff, and he taught us that basically bone is incredible. It responds to the mechanical loads and stresses applied to it. It can tell which way's up, which way's down, which way's left, which way's right. The cells all talk to each other with mechanoreceptors. So bone has an inherent ability to sense its environment. We also know that fracture healing entirely depends on a degree of the load being imparted to the bone. The bone needs to know that it's under what we call strain or stress. It's being loaded, and that can be either by pulled apart in tension or typically in fracture healing in compression. Two bits of bone need to be squeezed together to become one. This study was pretty cool. This showed us that the cells involved in bone healing, that's the osteoblasts, if you can't remember your basic science from medical school, those guys proliferate under loading. So if you have the right amount of loading of a skeleton, you will make more bone producing cells, which stands to reason in fracture healing is only a good thing. Furthermore, if you load the cells, they all line up in orientation to each other, whereas if you don't load the cells, they lie there not knowing which way is up or down. So the basic science tells us that if you move two pieces of bone relative to each other, you will generate callus, that's new bone forming, whereas if you don't move it at all, the bone doesn't bother responding. So again, I go back to that, it's a bit like sending your patient to space. If you lie them down and don't do anything, the bone turns itself off. We also know that these guys, all our rheumatologists and all our osteoporosis treatments involve weight bearing. Exercise is a treatment for weight bearing. Why? Because it increases your bone mass. So when you are next on a ward round, and you can ask yourself, where is the evidence for non-weight bearing? There is none. There is not a single paper out there that has shown improved clinical outcomes when a patient has been non-weight bearing versus weight bearing. Not a single paper. You also have to ask yourself, if you're going to give instructions to a 95-year-old with dementia that says, please use crutches and only put 30% of your weight through the leg, how realistic is that? We also know that even a patient who can take it in is going to do what the hell they like anyhow and put about 30% more weight through their limb than you think they're going to do. So this is not new, but the outcomes of frailty fractures have been really focused on in the last 20 years around the hip. The hip has been the driver. And for those who are in senior leadership positions, you'll know it's one of the metrics that the hospitals measured against hip fracture care. And it is kind of the benchmark. But the reality is any frail elderly patient with any fracture that keeps them off their feet suffers the same negative potential mortality and hospital morbidity that occurs with a hip fracture patient. And it is no different across the board. In amongst all of that, in the last few years, and this trial especially, and this is nothing to do with me, but Chris Brotherton and the guys at QML, they got that published in the Lancet, which for a randomized controlled trial in orthopedics to end up in the Lancet is impressive. All of these trials that looked at comparing the outcomes of one fracture versus another as to whether you could walk on it immediately or not showed no difference in complication profiles between the two groups and faster return to work and activity of daily living in the early mobilizers. So we are starting to see an evidence and a groundswell around this. We looked at some of this ourselves. We looked at our tibial plateau. That's the top of the shin bone fractures here at St George's. 110, 20 tibial plateaus out to 91 years old included in this group. No difference in outcomes or changes in X-ray appearances between the groups. And the same for our group of distal femoral fractures as well. No difference at all in the weight-bearing versus the non-weight-bearing groups. Indeed, our national guidelines tell us that in the frail and older trauma patient, we should be allowing them to weight bear after fracture surgery. So you'd think in the face of all of that, our orthopedic community would be really open to letting people walk on their broken legs. How wrong could we be? So I went to a conference a couple of years, 3 or 4 years ago, and we sat in a room and there was about 300 or 400 people in the room. We said, who's going to let their patient weight bear after this? And an X-ray went up and everyone's hand went up. What about this fracture? Everyone's hand. I was like, you're all talking rubbish. I know for a fact that can't be true. So this was one of our big data studies. This was the first study to look at actually what is happening for real, prospectively across the country in a group of patients undergoing fragility fracture surgery. So this was all patients over the age of 60 undergoing lower limb fragility fracture surgery across the country conducted. And this was one of my babies. So we had nearly 20,000 operations recorded in the study period. Those are all the hospitals involved. So it's an amazing snapshot of the entire country. And of the 20,000 patients, 95% that had a hip fracture were allowed to weight bear, and only 30% of patients who didn't have a hip fracture were allowed to weight bear. Now I put it to you again, this is the same patient, okay, same 90-year-old, 80-year-old, 70-year-old frail patient. If they'd broken their hip, one rule. If they've broken anything further down on the hip, totally different rule, which strikes me as crazy. When we went into that even further, if you broke your ankle and you're in your 90s, there was about a 90% chance you were told to be non-weight bearing after surgery, which is just astounding. And when we looked at this in more detail, we found that there was another issue. And one of the issues is the language that we use. As surgeons, we write an operation note and we prescribe a rehabilitation prescription at the end of the operation note, often using some sort of acronym about the amount of weight that the patient can or can't put through their leg. And we performed this study because I wanted to demonstrate from an evidence base that there was no uniformity in the language used and that there was no uniform interpretation of that language between healthcare professionals. So what the surgeon writes and what the physio, the OT, the nurse or the rehab teams interpret might be completely different. Let's take an example. PWB, partial weight bearing, is what people usually mean. But if you dig into the literature, you can find protected weight bearing as an acronym for it, progressive weight bearing, partial weight bearing, permissive weight bearing. So now we have 4 different PWBs. No one knows what any of them actually mean anyhow. And so we end up with this bonkers situation where the language that we're using to describe something really quite simple is totally varied across the board. So how do we get the leopard to change his spots? How do I convince my colleagues that they should let people walk on fractures after surgery? Well, the first was this paper that we've worked on, and this is about standardizing the language, because if we can standardize the language, we can research it much more accurately. And so we conducted a national consensus exercise, and it involved all of these groups. That's the British Orthopaedic Association, the Chartered Society of Physios, and the ATOCP. They're the main physio bodies in the UK, British Geriatric Society, the Royal College of Occupational Therapists, the Royal College of Nurses, physicians, GIRFT. I mean, we're talking the big players involved in the patient journey, and we have patient representatives in this group, and we essentially have come out with a new set of languages and guidance as a result of this research work around how we should be describing rehabilitation instructions for patients after fracture surgery. And the hope is that if we standardize the language, that we'll end up with a better quality of data that we can then instigate change in practice much more efficiently. Brilliant, right? I love this. It was like this was the orthopedic response from the orthopedic community. I presented this twice at the same conference. Once to the BOA has a physio day, so I presented it to the orthopedic group on one day, and this was pretty much the response. Like, I'm not changing. I've been using the same terms forever. Why should I bloody change? Like, did you not just listen to my talk for the last half an hour on exactly why? And then the physio lot were like, thank goodness someone's finally applying common sense to this situation. I know that it's controversial, but I think when you're challenging things, the whole point is you need to be controversial. You need to poke the bear occasionally. And for me, this is a really important part. We forget that there's 95% of the patient journey is spent in rehab. The transactional moment of surgery is very short, and we've really got to think about that bigger picture. But I'll also say, we know this at the moment, right? The NHS is struggling. You may have heard about that. I'm not sure. There isn't a lot of money left, and we're certainly not going to see lots more beds or new hospitals. So when we're sitting there jumping up and down about, you know, I need another operating theatre for more capacity, or I need to do X, Y, or Z, one of the very few things that we can control is perhaps how fast we can get patients up and out of bed and out the hospital. And if we were a bit more confident in mobilizing our patients as an orthopedic community, maybe as a medical community as a whole, maybe we would realize some more capacity simply by getting people through the system quicker. So that's my next part of work, is to look, and we're setting up a trial at the moment looking at the socioeconomic impact, the healthcare costs and the rehab journey of patients who don't wait there versus those who do after injury, to see what the actual impact is in the real world. So the final part of my talk, nearly done, guys, I promise. When things come along that are unexpected, what do we do? So I've talked about infection in orthopedics. I've talked about sometimes, you know, cases don't go well, maybe they end in amputation. In some ways, that's an expected unexpected, if you like. You know, things aren't always going to go well clinically, and so you can kind of build yourself and prepare yourself for those hits as and when they come. But occasionally, you know, trainees taught me there were some unexpecteds in the trainees' lives. Absolutely, there were. And I learned an immense amount about just how human trainees are. You sort of forget that you're, as a TPD, the biggest honor, the biggest privilege I had was being their mentor on the pastoral care side of things. And, you know, this is about me and it's not about their unexpecteds, but some of the stuff that came up made me realize just how varied and broad people's lives are, and the things people face are tough and challenging. I broke my ankle last year. That was a bit unexpected and irritating, but, you know, I navigated my way through it and we're okay. I also had a house fire a few years ago. This is my house. This is where it started. On the left, these are LED lights in the kids' basement den that went up in flames. This is the hallway down. Our whole house was black with soot like that from top to bottom. I can't thank the fire brigade enough for dealing with it. My wife and kids were in there at the time and they're watching now. And I learned something about resilience when I look at how my kids were after that. They were phenomenal. 9 months we were out the house, and that was one of the biggest challenges we've ever faced. And I certainly didn't expect that one to come along. But, you know, at the end of the day, that stuff was just material possessions. And it kind of made me realize an awful lot of that is replaceable. Also made me realize we don't own a lot of very sentimental stuff, but it was very replaceable. And it was more just, do you know what? It was an adventure in the end. We moved house 6 times over the best part of a year. We lived in a shoebox for half of it. But I think it brought us closer together, both physically and emotionally as a family. So taking the good from that was important. This was more unexpected. That's my ECG from a few years ago. I have no idea what it is, other than it's an ECG. But in the middle there is my heart doing something weird and wonderful. I'd actually been ignoring it for a good amount of time, but it progressively got worse over time. And I ended up having an ablation. It manifested actually properly when I was at a conference giving a talk like this, but to a couple of hundred people. Up in Edinburgh, and I pretty much keeled over on the stage, and I didn't expect that. Funnily enough, I thought I was really hungover, but I wasn't. It'd been the conference dinner the night before, and I kind of poo-pooed it, and we carried on trauma around Scotland, and then eventually I came back to George's, and those that know me is it reared its head again in the middle of or before an operation, and then it reared its head again the next night at home, and I ended up going home and having an ablation and coming back to work. But within a few weeks after having my ablation, something was just not right. And I still had weird palpitations. I was still feeling funny. And as a talk was coming up on the horizon, my next talk to give, I got myself in a right tiz. And that's the corner of my bedroom at home. I found myself sitting in that corner, composing an email on my phone to a colleague saying, here's my slide deck. You're going to have to give my talk for me. I just can't do it. And I ended up really quite hamstrung by my own mind. What happened to me after my arrhythmia on stage. And I can't thank enough these people, the NHS practitioner for health, who were phenomenal at offering me the support that I needed through a totally unexpected challenge. And the management of what turned out to be anxiety and generalized anxiety disorder after a pretty big life event. You know, I'm a surgeon, I'm an orthopedic surgeon especially. I'm meant to have an impenetrable force field around me and a massive hammer. And it's just not like that. And it made me realize that it's okay to not be okay at times. I still suffer with it today. Every talk I give, I brick it beforehand. I'm shaking, I'm nervous, but I've learned how to control it. And I've learned to realize that it can live back there and not influence me too much, but it doesn't go away. The magic tablets help, but you know, at the end of the day, we're all wired a bit differently. But I think even when you think you're invincible, stuff can come along that can really sideswipe you from a totally unexpected angle. So I think it's about getting back on that horse and building your resilience and building your toughness into how you respond to stuff that matters more than anything. So just a final few words and I shall be finished. There are definitely some people I need to acknowledge on this journey. These 4 people are my fellowship trainers, the main fellowship trainers, David Elliott and Kevin Newman, who are at St. Peter's, phenomenal surgeons and great mentors of mine. And then Badri Narayan and Durai Nayagam, 2 titans of limb reconstruction in Liverpool, who taught me so much. And without those guys, I wouldn't be doing what I do. I'm also very fortunate to work in a huge department. And I couldn't put all 25 of my consultant colleagues up here, but I've picked out 3 who've really been particularly special to me over the years. Duncan has guided me hugely on my journey through the university, through a variety of areas in education and academic work. Dom has been my sounding board, Dom Nielsen. He sits next to me in clinic and theatre every week. He was TPD before me. He handed me the reins, and he's been a level-headed sounding board for me. And Shami Umarji, who's just up there, has been probably the best of all at just being able to be my punching bag occasionally, has taken some pretty tough comments from me at times, but has really been a great supporter of me. And I can't thank her enough for all the moments where she's told me just to keep going, it's worth it. Come on, pull yourself together. These 2 chaps, Matt Costa and Will Erdley, have really been my mentors in the research world and have shown me the ropes and taught me a lot. And then these 3 chaps on the national policy front. This is Fergal Monsell, incoming president of the BOA. and my co-conspirator writing the national guidelines. Chris Moran, who was National Clinical Director for Trauma and was the Clinical Director for the COVID pandemic response for NHS England, has been a real mentor for me. And Bob Handley, who leads up GIRFT for trauma as well, have all shown me the ropes in my policy work and taken me under their wing a little. You'll have noticed I haven't talked about my family hugely. My family is very private to me, and Kirsty and the kids aren't here, not because they didn't want to be, but because we're other commitments. But it goes without saying that they are, without a doubt, the reason I can do this and the reason I do this. They make everything possible. They also make it the reason I get up every day and put my all in. Kirsty is my amazing sounding board. My kids are phenomenal. And I've got my picture there of my grandma, Betty. She was 104 when she died last year. She would have loved to have seen this, but she missed it just by a whisker. But she was probably my biggest supporter through my childhood and my early days. And without her, I don't think I would even be here where I am now. She's the one that kept me on the straight and narrow when I was a bit of a tearaway as a youngster. It wasn't quite true about my childhood being completely boring. So some final reflections. Challenges are a part of your life, and you need to seek them, I think, in my view, to improve your performance. If you don't challenge yourself, you won't better yourself. You also need to challenge the status quo, ask questions, and challenge dogma wherever you can. It's okay to not be okay. Things can and do go wrong, but the resilience that's inside all of us is key, and how we respond and how we build ourselves back up again is what matters. Coming back stronger is important. Push boundaries, adopt new ideas, but remember there are some founding principles underpinning what we do. Planning is absolutely key in life, I think, in certain areas. And the novel tech is great, but remember the principles that underpin it and don't forget those. Teach concepts and philosophy, not just facts. Logic tends to enable understanding, and I really believe that passionately. I also believe that training and teaching is a privilege, not a right. I think it's an unbelievable honor to be able to teach and train someone. Not all research has to be the big grant-funded studies, but look at what you do and find out where those research gaps are. You can ask questions and find a research gap anywhere. And finally, push yourself. You'll be amazed at what you can achieve, but own it. Own your journey. It's yours to own. Create your own opportunities. Build that resilience. Embrace determination. You will evolve and learn. So those are my thoughts to finish with. Thank you very much. There's me with a big bone. I believe my erudite colleague Duncan has a word or two to say.
I've got very few. My job, thanks, Alex. Thanks. It is to give the vote of thanks, which you've already done. So it's a slightly. Alex appeared here in 2013. I sort of vaguely known him as a registrar, and he appeared in 2013 as a consultant. Just this sort of whirlwind that arrived with this phenomenal knowledge, enthusiasm, pushing the boundaries immediately. And I remember saying to Dominic Nielsen, who was up there in the thanks, very early on, I'm a little worried about this guy. Because either he is going to be absolutely stellar, or he's going to crash and burn and have a breakdown pretty quickly. We had these conversations about it. I'm really pleased to see that he took the first option. I think all the stuff that's Alex done, we chat most weeks about things, and I'm permanently humbled by what he's doing. Just, sort of inferiority creeps in week by week. But the stuff he's doing is amazing. It pushes us, it stretches us all. It's lifting everybody, which I think is incredible. But I think on the back of it also, he's incredibly humble about all of it. He doesn't tell you half of what he does. And he keeps it rather quiet. He's not one of these people who's sort of bragging away on social media. And he's human. We've realised that. He's picked up enough problems. I mean, house fire, that's not a small thing. I saw my parents-in-law go through it. It's awful. Breaking bones is not fun. Being out of action, particularly as a surgeon, if you can't operate. And then cardiac things, none of us want those. I mean, looking at an ECG terrifies me at best of times. And he's done all of this stuff, but manages to keep going. So I think I learn a lot from Alex on a daily basis. I've learned a huge amount this evening. Thank you very much for giving us a talk. Congratulations again. And I look forward to the future. So thank you very much.